If the person you love suddenly clutches their chest, struggles to breathe, and looks at you with fear in their eyes, this is the moment that matters most. Heart attacks rarely announce themselves clearly. They don't always come with dramatic collapse. Often, they arrive quietly with discomfort, unease, or a feeling that something isn't right. Chest pressure that doesn't go away, pain spreading to the arm, jaw, neck, or back, cold sweating, sudden breathlessness, unusual weakness, nausea, or dizziness. When these signs appear together, don't wait for certainty. The most dangerous delay happens before the hospital. Families try to explain the pain. They call it gas. They call it stress. They wait, hoping it will pass. Heart attacks don't wait for clarity. If symptoms last more than 10 minutes, especially with sweating or breathlessness, treat it as a heart attack until proven otherwise. You don't need to diagnose. You don't need to be sure. You only need to act. Keep your loved one seated or slightly reclined. Do not let them walk it off. Do not leave them alone. Stay calm because panic increases the heart's workload. Your calmness becomes their safety. And then, call emergency services immediately. An ambulance is not just transport. It is treatment that comes to you. This single decision early changes everything that follows. When an ambulance arrives, something critical happens. Your loved one is no longer alone with the disease. Inside the ambulance is not just a stretcher. It is the first treatment room. One of the most important devices it brings is something families rarely think about: a defibrillator. Heart attacks don't only damage the heart muscle, they can suddenly disrupt the heart's rhythm. This can happen without warning. When the rhythm collapses, oxygen and CPR alone are not enough. Only a defibrillator can reset a lethal rhythm. Every minute without defibrillation sharply reduces survival. That's why reaching your loved one with a defibrillator matters more than reaching the hospital quickly in a private car. In an ambulance, the heart rhythm is continuously monitored. Dangerous rhythms are recognized immediately. A shock can be delivered without delay. In a private car, families can only watch. In an ambulance, action begins. Ambulances also bring oxygen, carefully monitored and correctly delivered. Oxygen supports struggling organs. It reduces strain on the injured heart. It prevents sudden drops that can worsen damage. Oxygen is not comfort. It is stabilization. There are also medications started early, each with a purpose. Some reduce clot growth. Some reduce the heart's workload. Some stabilize rhythm. Some reduce pain and stress. Pain relief is not kindness. It is treatment. All of this happens while the hospital is being alerted. Care doesn't start at the emergency door. It starts on the way.
When you arrive at the emergency department, things move fast. Monitors, electrodes, blood pressure cuffs, oxygen lines, an ECG within minutes. To families, it can feel chaotic, but this is not chaos. This is coordination. Emergency teams don't wait for perfect information. They assume risk because missing a heart attack costs lives. Sometimes, breathing becomes the first major problem, not because of panic, but because the injured heart cannot pump effectively. Fluid backs up into the lungs. Breathing becomes labored. Oxygen levels fall. Non-invasive ventilation may be started, a tight mask helping push oxygen in. But sometimes it's not enough. The patient becomes tired, agitated, confused. Confusion means the brain is not getting enough oxygen. That's when families hear the sentence they fear most. We need to put a breathing tube. Let this be absolutely clear. Intubation is not a sign of failure. It is a sign of protection. The tube guarantees oxygen delivery, reduces strain on the heart, prevents sudden collapse, allows safe movement for life-saving procedures. A patient who cannot breathe safely cannot survive definitive treatment. This is control, not surrender. While breathing is stabilized, another enemy remains: a blocked artery. If the cath lab is immediately available, the patient goes straight there. If not, waiting is dangerous. This is when emergency departments make a critical decision. We treat now, not later. Clot-busting medication may be given early. This is not outdated medicine. This is time-saving medicine. A partially opened artery now is better than a dead heart later. This treatment buys time. It stabilizes. It protects heart muscle. It does not replace the cath lab. It prepares the patient to reach it alive. After stabilization, the transfer is calm, monitor steady, breathing controlled, the team focused. This is what protection looks like. Later, families often say, "Everything happened so fast. We didn't understand." Now you do. Every decision, the ambulance, the defibrillator, the oxygen, the medications, the tube, the speed, was designed to carry your loved one through the most dangerous minutes of their life. You don't need to be a doctor to save a life. You need to recognize danger and act early. When you do the right things early, the emergency department can do the rest. Because in a heart attack, time is muscle, and muscle is life.
I want to tell you a real story. Not a perfect story, not a miracle story, but a story that shows how the emergency department cares for someone when life is slipping away. This is the story of a 62-year-old woman, and what happened when every minute mattered. She arrived at the emergency department on December 12th at 3:40 in the afternoon. She was struggling to breathe. Her oxygen level on room air was 72%. She also had severe chest pain. She had a known history of coronary artery disease. She had undergone angioplasty in the past. This was not an unknown patient. This was a high-risk cardiac patient in acute distress. An ECG was done immediately. It showed ST elevation in AVR, V1, and V2, with depression in the inferior leads. This pattern tells us one thing: a large area of the heart is at risk. At 3:50 p.m., within minutes of arrival, she received her loading medications orally. Oxygen was started. Non-invasive ventilation was applied. But despite NIV support, she was failing. Her breathing became more labored. Her oxygen levels did not improve adequately. She was tiring. This was type 1 respiratory failure. And now came the decision families often fear, but emergency teams must face. At 4:10 p.m., she was intubated in the emergency department, not because she had stopped breathing, but because she could not sustain breathing safely. Low oxygen worsens heart damage. Struggling to breathe increases the heart's workload. Intubation was done to protect her, not to give up. After intubation, oxygenation improved, monitoring was secured, her body was stabilized. This was control, not failure. At 4:17 p.m., 37 minutes after arrival, the next critical decision was made. She was thrombolyzed with 30 milligrams of tenecteplase. Why was this done? Because the cath lab was not immediately available, and waiting would have meant more heart muscle dying. This was not a replacement for angioplasty. This was a bridge to keep her alive. She was then shifted to the cath lab for rescue PCI. An intra-aortic balloon pump was placed. Advanced cardiac support was initiated. Everything that could be done was done. This was not delay. This was escalation. Despite early recognition, despite rapid decisions, despite advanced support, she passed away on December 14th at 2:42 in the morning. This is the part people struggle with. Emergency care does not promise survival. It promises that the patient is never abandoned. She was recognized early. She was treated rapidly. She was supported when her body failed. She was never left to struggle alone. Even when outcomes are tragic, care still matters. If someone you love ever reaches the emergency department in crisis, know this: there is a system, there is urgency, and there is care, even when the ending is not what we hope for. Because in a heart attack, time is muscle, and care is never wasted.